Hypercoagulability is the result of an imbalance between prothrombogenic and antithrombogenic or fibrinolytic factors. The coagulation cascade is illustrated in this diagram. Note the coagulation factors in red proceeding from top to bottom. The antithrombotic factors on the right side depicted in blue, and the fibrinolytic factors depicted in green. Cross-linked fibrin can produce D-dimer, which are fibrin degradation products. Primary hypercoagulable disorders. There can be a defective inhibition of coagulation factors, which include factor V Leiden, other factor V mutations, antithrombin 3 deficiency, protein C deficiency, protein S deficiency, and heparin cofactor 2 deficiency. The second is impaired clot lysis, such as seen with dysfibrinogenemia, plasminogen deficiency, TPA deficiency, and PAI-1 excess. And finally, promotion of thrombosis, as seen with homocystinuria, prothrombin G2021OA mutation, and histidine-rich glycoprotein. The activated factor V promotes the conversion of prothrombin to thrombin. It is normally inhibited by the activated protein. Factor V Leiden mutation. The prevalence is 3 to 6% of Caucasian population. Factor V becomes resistant to inactivation by protein C. This prolongs the thrombogenic effect of factor V. Mutation in one amino acid, arginine 506, is converted to glutamine. Most common cause of inherited prothrombotic state in 25%. 3% of the population is heterozygous for this mutation. The risk of thrombosis is increased 7-fold in heterozygosity, 20-fold in homozygosity, with increasing age, such as after 50 years of old, 21-fold with coexistent homocystinuria. Other mutations in factor V have also been described that promote thrombosis, FVH1299R and HVY1702C. Causes of activated protein C inactivation resistance. It includes factor V Leiden in 90 to 95% of cases, factor V H1299R mutation, factor V Y1702C mutation, lupus anticoagulant, estrogen treatment such as oral contraceptives, and pregnancy. Antithrombin 3 is a plasma protein that neutralizes the activity of thrombin and other factors in the intrinsic coagulation. It forms a complex with antithrombin 3 deficiency. Antithrombin 3 less than 5 milligrams per liter increases the risk of thrombosis. It can be hereditary or acquired, such as seen with consumption coagulopathy, liver cirrhosis, nephrotic syndrome, leukemia, malnutrition, inflammatory bowel disease, treatment with L-asparginase, and from the use of oral contraceptives. Protein C is a vitamin K dependent plasma glycoprotein that binds to thrombomodulin in the endothelium, where it is activated, and then in conjunction with protein S, proteolysis factors activated 5 and activated 8, shutting down fibrin formation. Protein C deficiency can also be hereditary, the types 1 and 2, as well as acquired. The acquired forms include disseminated intravascular coagulation, acute respiratory distress syndrome, hepatic dysfunction, and treatment with L-asparginase, like with antithrombin 3. Protein S is the cofactor that binds activated protein C to accelerate its antithrombotic activity. It is a vitamin K-dependent protein. Protein S deficiency can also be hereditary or acquired. The acquired forms include disseminated intravascular coagulation, systemic lupus erythematosus, HIV infection, hepatic disease, nephrotic syndrome, the use of oral contraceptives, and normal pregnancy. This fibrinogenemia, the majority of these fibrogenemias cause bleeding and not the thrombosis. Several variants produce a rapid release of fibrinopeptides that produce thrombosis. It can be hereditary or secondary to liver disease. Homocystinuria. There are 7 distinct homocystinuриas. Increased in homocysteine levels in plasma, not necessary in urine, is an independent risk factor for vascular thrombosis. Increases thrombosis by altering the endothelial metabolism, increases the platelet adhesiveness, and produces thrombosis in venous and arterial systems, in the arterial tree, the coronary, the renal, the brain, and peripheral. Secondary hypercoagulable conditions include patients who have visceral malignancies, pregnancy, obesity, the use of oral contraceptives, the nephrotic syndrome, myeloproliferative disorders, hyperlipidemias, diabetes mellitus, paroxysmal nocturnal hemoglobinuria, postoperative states, vasculitis, the antiphospholipid syndrome, increased levels of factor 7 fibrinogen, and heparin thrombocytopenia. Antiphospholipid antibody syndrome. It can be divided into primary and secondary. The secondary forms include connective tissue diseases such as systemic lupus erythematosus, systemic sclerosis, that is scleroderma, Sjogren's syndrome. The drug-induced forms are related to products such as hydralazine for treating high blood pressure, prokinamide, that is an antiarrhythmic medication, quinidine, phenytoin, phenothiazines. Infections include the human immune deficiency virus, Lyme disease, malaria, and Rocky Mountain spotted fever. Miscellaneous conditions are Behçet's disease and Schneider's syndrome. Phospholipid antibodies can also be found in healthy people. Antiphospholipid antibody syndrome. Clinical features are venous thrombosis, 30%, and pulmonary thromboembolism. Arterial thrombosis include the brain, the heart, and the peripheral circulation. Recurrent pregnancy loss, thrombocytopenic purpura, heart valve abnormalities, livedo reticularis, myelopathy, and chorea. Positive anticardiolipin test, positive lupus anticoagulant. And many patients require high doses of warfarin or subcutaneous heparin to treat the physiologic states predisposing to thrombosis. They include pregnancy, puerperium, obesity, postoperative states, immobilization, and